Good afternoon and welcome to the Online Journal Club, session number 2. We're going to be starting in just a few minutes.
Yes. So I'm now presenting to everyone. Hi, everyone. I'm Rob. To my left is Hayden. And we're lucky enough to be joined by Etienne St. Louis there in the little box. And brief introductions again. I'm one of the attending surgeons at the Children's Hospital. This is the second journal club that we're hosting via the Hendren Project. Hayden hails from Texas. What part of Texas? Tell me exactly where.
Northeast Texas.
Northeast Texas, east of Dallas. There. Yeah. So, so he's good enough to be with us today, taking an hour out of the OR to talk about not operating on kids for a change. And Etienne, thanks again for taking a bit of time away from ClinEpi.
No problem.
What I want to do now is screen share for a second. Pardon me, and I just want to. Here we go. Share this. So hopefully, Marcy, you can confirm with me, but what you're seeing there hopefully is an introduction to the Online Journal Club, or at least our slide. Let's just get that started. There we go. Okay. So listen, what I wanted to do is just take 5 minutes and recapitulate sort of what we talked about last session. Last session, Etienne was present for, and we had a pretty in-depth discussion of a systematic review and meta-analysis of basically pain strategies for kids getting inguinal surgery. And the paper we looked at was an open access article by Shanthana et al. Perhaps the first key point that we learned about was the wonderful nature of open access journals and how that's kind of really changing the game with regards to getting more and more people able to view evidence. So this was an open access article, and we spent some of the key learning points that we just wanted to recapitulate was, what is a systematic review? And if you look up definitions of review, of different types of medical reviews, you'll find 13 or 14 that exist, everything from a scoping review to a comprehensive review. So the key term that sets a systematic review apart from the others is systematic. And for a review to truly be systematic, it requires a search strategy. And the search strategy in and of itself is publishable and should be reproducible. In other words, it's transparent. And to complete the requirements of a systematic review, you have to critically appraise the literature that's included into the systematic review. What that amounts to is a risk of bias assessment. And that risk of bias assessment can be done a number of different ways. I endorse the Cochrane tool, Cochrane, and it's a wonderful tool of just assessing how valid or invalid the articles included are. And you can do a good systematic review and have it stop right there. And I think that's something that most people do not appreciate, is that a systematic review can begin and end with a qualitative assessment of what's out there in the literature. Most people, however, prefer, as a writer and prefer as a reader, to see a quantitative tabulation of results. And so that is called a meta-analysis. And that, again, is an optional aspect of a systematic review. And the paper that we looked at did have a meta-analysis, and here's sort of a snippet of the one of the forest plots. And I think the key mathematical principle here is that you just can't add up events or non-events from different studies and come up with a summation and have it be valid. And the reason for that is each study has its own inherent variability. And if you do not account for the inherent variability of each study, you will bias your results significantly. And that's the fundamental difference between just addition and a true meta-analysis. You can use a bunch of different software, but again, I'll refer back to Cochrane because they have freeware that you can download called RevMan, R-E-V-M-A-N. We're up to, I think, variation number 5.2. And it's an excellent tool, but like any tool, it has to be understood. So one of the keys about deciding whether or not you can proceed with a meta-analysis is to determine the heterogeneity of papers included in the review. And if you look at this forest plot, and the forest plot is just the quantitative analysis of your systematic review, you'll see here that, and I'm bringing my cursor over to the I-squared statistic and the chi-square here. Those are both measures of heterogeneity. And the easy rule of thumb is an I-squared statistic at 0% or as low as possible suggests good homogeneity. Whereas if an I-squared statistic starts to creep up to 1/3 to 2/3, then you're getting into territory where you should watch your analysis carefully and or not even perform it. The other way you can check for heterogeneity is the old eyeball test. Have a look at these values here. Each little dot represents a point estimate, and the arms on either side represent the error. And you'll note that all of these point estimates cross the line of no difference and are all relatively close to one another. If you were to have a series of studies where some are right here on the right-hand side, suggesting a improvement with intervention, whereas others are on the other side, that suggests that those studies are just so different they shouldn't be melded together. Finally, recall that the cumulative point estimate is estimated using the diamond, which is here. And it's graphically represented here, and then you've got the summary statistic here, which shows a subtotal in 95% confidence intervals of 0.8 and 0.62 to 1.04. And that means it just crosses 1, and that means the ultimate result does not meet statistical significance. All of you will remember that p equals 0.09 means we didn't quite get the usual threshold of p equal to 0.05, so we would say that that result is not statistically significant. So that's kind of my 5-minute recap of kind of the key takeaway points to look at a systematic review and to at least understand the basics of a meta-analysis. For further discussion, I'd ask anyone who's watching this and interested to go ahead and look at Journal Club number 1, or to go ahead and contact me for further discussion. But enough of that, guys. Let's talk now about today's article, because today's article, I think, is kind of hot off the press and something that a lot of us in pediatric surgery are talking about, and that's the non-operative treatment with antibiotics for children. And I just want to double check, first of all, that we still have Hayden here, yes?
Yes.
Good man. And then Etienne, are you still there? Uh-oh.
Yes, I am.
Okay, thank you, Etienne, sorry. I'm just, and am I right that you're looking at my slide, Etienne?
Yes, I am. You're correct.
Great. So at some point we'll go back away from the slides, but for now I just wanted to introduce the article to everybody. It's published very recently in the Annals of Surgery, which suggests Annals in general has a pretty good impact factor. It's pretty well regarded in surgical circles. And today I wanted to just articulate a little more clearly what the learning objectives were. So I really wanted to spend a moment and understand the advantages and limitations of a pilot study, because that's what this is. I wanted to review briefly what a type 1 and type 2 error was, because it has important implications with regard to going from a pilot to a full study. We'll talk a bit about what an RCT flowchart is and what the consort statement means. And then I wanted to review some of those key concepts surrounding randomized trials, including equipoise, randomization, minimization, blinding and allocation concealment. And then I promise I don't want to just keep blabbing on, so we'll get to some discussion here in a sec. All right, a bit of background to make sure everyone's on the same page. So appendicitis in kids we know is common, and I grabbed some of these statistics from pretty recent epidemiological data. And it suggests that about 300,000 procedures are done every year in North America, and that's just adding up American and Canadian data. And as is no surprise to pediatric surgeons, the most common age group for this entity to occur is young adults, age 10 to 19. It happens a little more frequently in males. Your guess is as good as mine as to why that occurs. In pediatrics, about 2/3 of patients, and that's sort of simplifying things a bit, but in general, about 2/3 of patients have simple appendicitis. Hey, maybe Etienne, do you know some of the risk factors for perforation?
Yeah, I mean, duration of symptoms.
Yep.
More than 24 hours, typically, patients have a higher risk of perforation.
Yep.
If they don't receive treatment within that time, obviously, so in the form of antibiotics, they can perform surgery.
Yep.
If they have, for any reason, you know, anything that that would cause them not to have the symptoms expressed, even though they've been having them for a long time. So an inability to communicate their symptoms, or an inability to to even feel the symptoms if they're on certain medications or things like that.
You're right. Simplifying that statement, what's the most common type of patient who can't articulate what's going on well?
Well, any child with a developmental disorder or a speech impediment or anything like that.
Those are all true. I think Hayden's shaking his head, though, because he has a simpler answer. Go for it.
Young child.
Yeah.
Sure. Yeah, obviously.
Yeah. So kids 5 and under, that number's a bit arbitrary, but young kids, toddlers, for example, if they're going to present with appendicitis, have a much higher likelihood of perforation. But I don't disagree with everything else you just said. So kids with neurologic impairment or other reasons why they can't articulate their symptoms, those also would have a higher risk. They're just a little more rare in our population. Interestingly, another study showed obesity in and of itself is a higher risk factor for perforation in pediatric population. Why that is we're speculating, but another reason to watch our weight, I suppose. So needless to say, we all know it remains the most common emergency surgery in children. And the standard of care, for sure, is to do an appendectomy. And as we all know, we kind of moved away from the era of open appendectomy, and more have embraced laparoscopic appendectomy as pretty much the standard operation. There's certainly nothing wrong with a good open procedure, but I think more and more the large-scale epidemiologic data suggests that most kids these days are being treated with a camera. So what about not operating at all, however? Etienne, you and I are from Montreal, and we'll remember our hockey lore. Patrick Roy, who's a famous goaltender for the Canadiens, was in the middle of the playoffs and had right lower quadrant pain. Presented to the hospital, was diagnosed with a CT scan to have appendicitis, but had to play and get into goal to help the Habs win the Stanley Cup. So he was treated non-operatively with antibiotics, and he had a favorable outcome without an appendectomy. And so when people hear about that, they say, well, okay, that sounds good. I'd like that too. What is ultimately the outcome then of, the evidence for non-operative management of anyone, kids or adults, for appendicitis? Well, there's not that much. So there have been several small trials in adults that have suggested that at very least it's safe. It's not been shown to be cost-effective and not been shown to have other benefits. And we're going to defer a discussion later on about a fairly large Scandinavian study that tried to look at whether it's non-inferior or not. We'll get to that later. But the point is, there's some evidence in adults that it might be reasonable. And in kids, up until this study and a similar one that we can allude to, there's been only one small retrospective series that it showed similarly that it's safe. The children, if at least treated with antibiotics, don't go on to die of appendicitis. But this is really, we're at the beginning of trying to compare outcomes between non-operative and operative intervention for a simple appendicitis. The other thing I want to mention just before, just so that we're clear, is I don't want to discuss people with contained perforated appendicitis, and that's sort of over here at the top of my slide. So there's certainly patients who have had 7 to 10 days worth of symptoms, for example, that have had their severe fever and that have burst and now have a contained abscess. There's certainly a subset of those patients who can be managed with a drain and antibiotics and have their appendix operation either deferred or not performed altogether. But we're talking about a different population here, a patient with presumed simple appendicitis. Does that sound okay, you guys?
Yes.
Wonderful. Okay, sorry, a little awkward, isn't it? All right. So here's the article again, and what I wanted to do is circle the word pilot. And I wanted to spend a few minutes here to discuss what you all thought about the word pilot. And I want to open it up now, and I'm going to actually stop screen sharing for a second. How I do this here. We're going to stop screen sharing. So, hold on a second, stop sharing for a second. So I think now we're going to just see ourselves again. Give me a second. There we go. So what do you guys think a pilot study means? What is that? What are we talking about here? And I'm going to just turf it to Etienne as for the first shot. What does a pilot study mean?
Well, my understanding of it was that pilot studies purpose, there are multiple purposes or can be multiple purposes. The first would be to get an idea of what kind of effect you can expect from your intervention. And the reason why that's important is because to do large randomized clinical trials can be very expensive. And you know, often if you want to have a significant result, or you want to at least show that whatever result you have is valid, you need to power the study appropriately. And to do that power calculation, to get an idea of the sample size that you're going to need, you do need to have an idea of what effect you can expect. I think another issue that the authors raised in the paper here, and I think was well put, is the idea that recruitment for kids in a randomized control trial, when there's really true equipoise, so really unknown. It's really unknown whether this new treatment or new approach to treatment is beneficial compared to the standard of care. Sometimes, or often, it can be very difficult to convince parents, in this case, to enroll their kids in a trial. Specifically when this is not like a diagnosis of desperation. Appendicitis is very common, as you pointed out, and there's a commonly accepted and generally well-tolerated treatment. So to offer parents an alternative that doesn't have very much evidence to support it is difficult to do. So those are the two main advantages of a pilot study that I thought of. And the other thing is just feasibility. And again, this ties into the complexity and costliness of running a large randomized control trial, seeing whether or not the estimates of recruitment that the authors stipulate based on their own volume and stuff like that, whether it's going to be actually just feasible to conduct the trial over the desired period of time.
Yeah. So I think in general, just to summarize your comments, one, I think most people would agree that feasibility is a very important parameter worth reviewing during the context of creating a pilot. Can you successfully run the protocol? And there's a lot of aspects to that. We'll look at that in a second. Two, generation of a power calculation. Now, that's a traditional function of a pilot study, but I'll suggest to you, and I'll submit to you, Etienne, that actually is probably not what we should be doing, even though the authors did it, and it's a commonly held belief that pilots are used to power larger trials. That's probably not what we ought to be doing. I just, this is taking the perspective of a clinician epidemiologist, for example. And the third reason is that's traditionally cited is for safety reasons. So let's say we're kind of, the pilot study is in general exploratory, right? You're trying to look at something for the first time or in a preliminary fashion. Maybe you're looking at a new drug for the first time or a new intervention. So you don't have a lot of background data, and the pilot can help decide whether or not, man, this is crazy. We've had 3 unexplained deaths with this new treatment versus none with the old treatment. So maybe we shouldn't be doing a study on this at all. Maybe we need to go back to the drawing board. So those are just some of the things to consider. I'm going to go back and head over to my slides again. And just to summarize that again, let me see if that works. So in general, and thank you, Etienne, because without prompting, you've more or less articulated a lot of things. So really, the pilot's there to assess feasibility, safety, and generate the sample size. When it comes to feasibility, this is a bit slow. So it can, what do I mean by feasibility? Well, it can look at a lot of different stuff, right? It looks at how well are we able to screen patients? Can we recruit them into our study? Is our randomization technique okay? Are we losing patients, like to attrition for one reason or another, if we have a long follow-up, for example? How often are people put in one arm, staying in that arm? That's called crossover. And if you have too high a crossover, your study starts to fall apart. Treatment fidelity refers to, again, are people being treated in the way that we believe that they're going to be treated? Are there, for example, previously unknown confounders that are going to mess with the validity of the study? And finally, are we able to kind of look at the outcomes the way we expect to look at the outcomes? Is our assessment of those outcomes adequate? So, so all those things are true with regards to feasibility. Now, with regards to stuff like safety, in general, a pilot isn't the greatest way to do that because you're supposed to have too small of a sample size to actually make meaningful comments about safety of X versus Y. What you should do, at least, is ensure that your adverse event reporting system is intact and functional. However, as I say, there are exceptions to the rule, and even in a pilot study, if there's an unexplained spike in adverse events, obviously that's the sort of thing that would have to be reviewed before proceeding to a large trial. And then finally, this question of generating a sample size. So I have to admit, before really researching this presentation, that was my assumption too, Etienne, and it's a very widely held one. But it's not actually the correct one. And why is that? Well, because your pilot is a small sample of a larger sample. And the idea is the pilot's supposed to represent what's going to happen in your sample. And in general, your larger sample of your trial is supposed to represent what's going to happen to your population as a whole. Therefore, if your pilot effect size is incorrectly big or incorrectly small, it's going to adversely affect how you power your study. What do I mean by that? Well, now we're starting to talk about type 1 and type 2 error. So if a pilot effect size is incorrectly big, what would that be called? We have to think it through a little bit, right? Hayden, can you help what that sentence, if pilot effect size is incorrectly big, is that a false positive or a false negative?
So I think you would have a false positive effect.
That's right. We call that a type 1 error. Okay? If a pilot, if any error, if any effect size is incorrectly big, it means it's seeing an effect when maybe there isn't one. That's a type 1 error. Okay? The opposite is if the pilot effect size is incorrectly small, that means it's kind of not seeing a difference when it does exist. That's a type 2 error. So which error do you think is worse? Which error do you think we generally try to avoid in medicine more? That's kind of a philosophical question. What do you guys think?
I would say probably type 1.
We do. We do. And I want to just, there's a good reason for that, right?
Yeah.
So let's think it through again. So type 1 error is incorrectly saying there is a difference when in fact there is no difference. And that's a little more, that's worse than not being able to detect a difference. Okay, let's pretend you have a drug. You think it works or it doesn't work. It's much worse to make the mistake that thinking it works when it doesn't, and all of a sudden everyone's getting this drug, versus the reverse, which is rejecting the use of that drug when in fact it might work.
There's do no harm.
That's right, exactly. I think that's well put. It's the idea is we don't want to do harm first. Secondly, we like to show something works, and that's the difference between a type 1 and type 2 error. So most studies, again, most medicine in general tries to avoid type 1 before type 2, but those two things are both important when it comes time to power a study. So the reading that I did said rather than use pilot data, you know what, the better alternative to designing a meaningful randomized trial is ask what is the smallest clinically meaningful difference that you want to detect. Okay, so let's say, for the sake of argument, laparoscopic versus laparoscopic versus non-appendectomy. What's the biggest or the smallest meaningful difference in, for example, abscess rates or wound infection rates? If you say it's 5%, if that's meaningful to you, then that's probably a more rational reason and way to do a power calculation at a sample size than it is on some of the pre-existing data. Does that make sense? Now, I'm not going to suggest that people that use pilot data are crazy. That doesn't make that's not true. Pilot studies should help inform how studies are performed, but interestingly, I think sample size calculations are probably better done by asking what is the clinically meaningful difference. Okay, So getting back to this particular study, this is the HTTP, or the online address for this study. It's also open access. And I wanted to just take a moment and acknowledge that you kind of have three types of journals out there in the world. You have online open access journals, you have more traditional restricted journals, and then you have some that are in between. And Annals of Surgery is one that is in between. And what does that mean? It means you have the option, the authors do, of paying for an article to be open access, in which case it's accessible to everyone. And that's what was done for this particular article. And there's how you access it. All right. This is just a reminder of where we are on our pyramid of importance. Randomized controlled trials, as we know, represent pretty close to the top of the pyramid of levels of evidence and quality of evidence in medicine and surgery. And then let's get to the nuts and bolts of this particular article. So we'll, as per usual, appraise it in three ways. We'll look for its internal validity. We'll just summarize the results, and then we'll ask, is it useful and generalizable to us, me, in our context? So what's the question? Well, I kind of summarized it here. Now let's talk about the advantages and disadvantages of each decision that these folks made for their PICO. So again, PICO stands for population, and they decided to limit it to children aged 5 to 15. So why not 0 to 18, for example? Anyone have an idea about why 5 to 15? Anyone think that's a good idea, bad idea?
Well, we kind of already talked about the 0 to 5 age group is more likely to be perforated.
Yeah.
So.
Yeah, I think that's an easy reason to exclude them. Also, for reasons of ethics, sometimes those folks are harder to consent, and ethics review boards can be a little more sticky about patients that can't even assent to participate in a trial. I hadn't really expected to talk about this, but consent usually is taken from the subject, whereas assent is taken from the subject not to participate, but just simply to provide assurance that at least it's understood that they're participating in a study. So for most pediatric trials, often consent is sought from the caregivers, but assent is usually sought from the child. And kids under the age of 5 really often lack the comprehension to either provide consent or assent for trial participation. But here's another question. Etienne, what do you think? Why not add people age 16, 17, and 18?
Well, I think the question here is, you know, given that the idea of looking at antibiotic treatment in adults has already been looked at before, the interest here is to look at children specifically, and I think maybe the author's rationale is that from the age of 16 onwards, the children in those age groups are going to be physiologically, I mean, pretty identical to adults. So I think that might be why they decided to exclude them, but I'm not sure. There might be another reason that I'm not thinking of.
Yeah, no, I think that rationale makes sense, but there might be a more pragmatic reason. A lot of pediatric centers sometimes will limit their practice to not necessarily 18, but sometimes 16 or 14. So this trial took place at the Karolinska Institute in Sweden. I don't actually know what their cutoff is, but my guess is they might actually send kids 15 to 16 and over to adult sites. So I think it's probably a more pragmatic reason. That's my guess anyway, but I have to admit I'm not sure. And then how about the intervention? So here's what they chose to do. They said if you're not going to have surgery, then we're going to at least admit you. I'm going to give you 48 hours of antibiotics. And as far as I remember, they hit them with both meropenem and flagyl, which is a pretty serious antibiotic coverage. And it required at least 48 hours of admission, sometimes longer. And then the control, the good old control, is appendectomy. And I recall reading that they said any kind of appendectomy would do, but when they looked at the results, everyone got a laparoscopic appendectomy. So that's nice because that kind of, I think, aligns with what most of us do here in North America. And then their outcomes of interest were symptom resolution. And symptom resolution, that's a bit vague, isn't it? And they kind of said short-term symptom resolution versus, and they looked at one-year outcomes. Being be that as it may, that's sort of their PICO question. We can debate whether or not there's any other outcomes maybe they should have looked at or forgot to look at. But I think simplistically, that's a pretty fair look at what we're really interested in as a primary outcome. So this slide probably won't project very well, and I apologize. I'll just try to stretch that a bit. So this is the consort diagram, if you will, of what happened to all patients that were considered eligible for this study. And it's worthwhile to work our way through this a little bit, and I apologize if this isn't very legible. But to make a long story short, they looked at about 225 kids and excluded 3/4, more or less, a few because they were not of age, about 1/3 that just declined. Oops, they said no thank you. 39 that were perforated, so there's kind of a perforation rate of, what is that, I guess 15 to 20%. Previous non-operative treatment is interesting, so you got 5 people that already had this attempted once. 37 that were never asked, that's interesting. 2 that were excluded by the investigator for one reason or another, and then 1 that had a randomization failure. So from 225, they boiled it down to 51 that were randomized. And of those that were randomized, sorry, didn't mean to do that. Let me see. They had 25 go at the antibiotic arm and 26 go to the intervention arm, and there were no crossovers. You'll see no one here immediately went and got an operation or vice versa. None were lost to follow-up, and they all were analyzed at 1 year. So at the very least, you had no loss to follow-up. But you had 1, that withdrew after randomization because they didn't want to be probably in the antibiotic arm, which is a little bit fishy. But that is sort of the patient flow. And then a couple of questions just to review is, what was their randomization scheme, guys? So, because it was a little bit interesting, I think. I don't know if you guys remember the details of it. Etienne, did you happen to catch that?
Yeah, so they used a term that I didn't recognize. They called it weighted minimization, but my understanding is that they've basically done a stratified randomization. So they in the design phase of their study, they identified factors that they thought might have an impact on the outcome. So they looked at age, gender, the duration of symptoms. I think those were the only 3, and then they used that as basically as 3 factors that they would want to make sure that were equally distributed in their randomization. And the importance of doing that here is because they have a relatively small size of their sample. So the probability that the randomization is going to be perfectly successful with respect to measured and unmeasured confounders is lower. So it's interesting that they did that. I think it's a good idea, and it's a good concept to be aware of. But I'm not sure if weighted minimization is exactly the same as stratified randomization, but it sounds like, just from reading the paper, it sounds like that's what they did.
Yeah, no, I think you've explained that pretty well. And more trials are using this process called minimization. And the term just means minimizing the differences between the 2 groups. As you know, as you alluded to, if you flip a coin enough, sooner or later, things will equilibrate. But as you begin your flipping, the first 10 flips, you might have 8 heads and 2 tails. And if you do 50 flips, you might have 35 heads and 15 tails. And that's just random chance. And so to minimize stuff, what these researchers have done, I think smartly, is say, listen, there are certain things that we don't want there to be differences on. Gender, age, and duration of symptoms, right? And so what they do, imagine a scale, and on each side of the scale are 2 arms of the study. And on one arm, you put a patient. You put a 6-year-old boy with 6 days worth of symptoms. And the scale drops a little bit. The next patient shows up. And what you want to try to do is allocate that patient to whichever group will balance the scale best. So the process is not completely random, actually. The computer uses an algorithm based on what you've inputted and says, because this new patient has arrived and I have to decide to put him in the intervention arm or the control arm, I'm choosing to put him in the control arm because that's what's going to level the balance best based on the factors that we just mentioned. Does that make sense? I think you described it nicely, Etienne. I don't know if I did a better job than you did, but I always like the idea of a balance and trying to keep the balance, and that's what the computer is doing. So then, is it truly randomized? It's kind of a philosophical question. Kind of no, because it's not actually completely random. It's still considered a form of randomization, a form of a patient allotment. But strictly speaking, the allocation is not entirely concealed, at least from the computer. So the computer kind of knows, for example, that the next girl that arrives, for example, will have to go into the control arm because we got not enough girls in that arm compared to the intervention arm. So the computer has that in its little brain, and the computer will then allocate that patient. But the idea is the computer is also able to conceal that allocation to us. And that's important. So, and it's frequently misunderstood. Randomization is just, are the two groups, is it random where they're going to go? And allocation concealment is, do you have a way of shielding and not knowing where the next patient is going to go? Does that make sense? It's a slightly different concept. They're related but different. Yeah. All right. So in general, then when we talk about the internal validity of the study, we ask ourselves, were the groups similar? So I'm just going to skip ahead a bit because, and this hopefully projects well enough, but the study did, I think, exactly what they ought to have done, and they gave us all the baseline data as best they could about all the kids that were randomized, all those that said, no, thank you, I would prefer not to participate, and all those that were not invited to participate. Okay, so of the 250, I think it was, that originally, how many showed up? Originally about 225. Of 225 that showed up, you've at least got demographic information on 2/3 or 3/4 of them. And so you're missing a few, but why do you think this table matters?
Well, this table is important because it shows us that there was no bias in selecting the study participants.
Yeah.
So whether it was intentional or whether it was just due to any other factor related to the reason why the family or the patient declined, or why they were not invited to participate, these are factors that are hard to measure. But by showing that the groups are essentially equivalent, the authors are showing us that they don't believe that there was any bias introduced there in the selection of the study participants.
Yeah, and I think it quickly it increases your generalizability. Did you note that there is one statistically significant?
There is one, yeah.
Yeah.
The duration of symptoms.
Yeah, duration of symptoms. So they actually do comment that maybe people that weren't invited to participate had shorter duration of symptoms. Is that right?
No, the opposite.
The opposite. Hold on a second. Duration of symptoms less than 48 hours. 25 or 68% versus 86%. Yeah. So those not invited, am I correct, had shorter duration?
He had
Am I reading
longer,
that right?
had longer. So there was a higher percentage of patients randomized that had duration less than 48 hours as compared to 68% that.
Yeah. Right. So duration of symptoms less than 48 hours.
There was more patients in the randomized group.
Yeah.
Than the not invited group.
Yeah. So the not invited group
had longer duration of symptoms, the way I understand that.
Well, wait a minute. Duration of symptoms less than 48 hours, 86% here, 68% here.
Right, so a lower percentage of these patients had symptoms less than 48 hours.
Right, okay, gotcha. Sorry, my brain is working slow.
That's it.
What that means is, okay, so because you have 1/3 of patients here that had long symptoms, and you had maybe 15% here, you might argue that some of these people not invited were not invited because people thought, well, these people are pretty sick, and I wouldn't want to treat them with antibiotics alone. Perhaps, right? You can't know that for sure, and it's a small sample size, but that certainly raises a little bit of a suspicion about what that signifies.
Yeah.
And then they went and they looked at the surgery versus non-surgery group, and they just looked at they compared those two people with regards to were those two groups even. And basically, this is just a little referendum here on was the minimization process well done. And what you do not want to see is a significant p-value here, right? So you don't, and things look pretty comparable if you do the eyeball test, right? 11 versus 12 years old. Males were again, more or less the same. So it suggests that at least we've got relatively apples to apples, yeah. But now, I'm just going to move along. So were the groups treated in the same way? And I wanted to try to answer that question and then refer back to a quick website here. Were they treated the same way? Well, that's the kind of question that we usually ask when we do a critical appraisal of a randomized trial. But this one's a little tricky, isn't it, right, guys? Because their treatment is vastly different.
Mm-hmm.
So you can't, I would say, this usual question that we look at when we assess the effectiveness of this trial, we kind of have to push to the sidelines a little bit. Does that make sense? Because what you're asking here is not really, is treatment, is this one pill better than that one pill and everything else is the same? It's, is one treatment philosophy superior to another treatment philosophy, or at least equivalent, or anyway, we'll discuss non-inferior, you know, what is the association between one treatment philosophy versus another? So we'll scrap that question on purpose and move along to the question of, okay, boom, the question of blinding. And shoot, that's not right, is it? Let's just, doesn't look good, does it? Anyway, my achieved is misspelled. Here we go. So, blinding, right? Briefly, it didn't appear that anyone was blinded, right?
Mm-hmm.
Can you blind in a surgical trial at all? Is that possible? Have you heard of that?
Yes, yeah. But not. I mean, you can if you're comparing with, let's say, placebo, and I've heard of like sham surgery as a control, but it's rare.
Yeah. So there have been a couple of pretty famous studies of arthroscopy, for example, where they'll put a person to sleep and either do actual arthroscopy versus put 3 little nicks in the skin. That's pretty rare, though, and these days you'd be hard pressed to get that through ethics boards. There are such things, however, as good blinding for some pediatric studies, like lap versus open pylorics, where you'll do one surgery or another, and at least in the short term, put a bunch of bandages on a baby so that whoever's assessing that child can't see what kind of scars they have. But here's an overarching, larger question. You guys have all heard of a single-blinded study, double-blinded study, sometimes even triple-blinded study. Do you guys know what that all means? What is single, double, triple-blind? Any guess?
Yeah. So, I mean, correct me if I'm wrong, but I think single-blind is when only the study participant is blinded, or I'm not sure if it's specific to which person is blinded, but single-blinded means that only either the researcher or the study participant is blinded.
Yeah.
Double-blinding is when they're both blinded to the intervention versus control. And triple-blinding, I'm not actually certain. I think it's when the people who are analyzing the data. I'm not 100% sure on that one, to be honest.
Yeah. So you did a nice job of explaining why it's confusing, and more people are acknowledging that those terms are antiquated and should be thrown into the garbage bin. And you've nicely identified that there are 3 stakeholders that should ideally be blind. One is participants, 2 is the caregivers implicated in the trial, and then 3 are the outcome assessors. And so a good study won't say single, double, or triple. They'll say patients or subjects are blinded, or the clinicians are blinded, or the outcome assessors are blinded. That's just unambiguous. Of the 3, which do you think is most important? Or are they all equal?
I think the outcome assessors blinding should be the most important.
I would generally agree with you, but it depends a little bit. So, for example, some outcomes are very subjective. For example, if I was doing a study of pain scores in little babies and had to look at their face and rate their face to decide who was in more pain than another, that outcome assessor has a lot of impact on the data at the end. But another counterexample is, let's say my outcome is systolic blood pressure or hemoglobin level. So my outcome assessment isn't really going to affect that hemoglobin level. It's based entirely on what the computer tells you or the lab tells you. So in certain instances, like blood pressure, it could be the opposite. It could be where the patient actually does have a large say on the ultimate outcome. And a good example is a placebo versus non-placebo typical, cardiology heart drug. Um, Blinding there is important because the psychology can greatly impact the outcome of interest. Does that make sense? Particularly for surgical trials, when you're talking about stuff like surgical site infections or other things that are kind of subjective in their assessment, in general, the outcome assessor is the most important to be blinded. But what do you think about this study? Could it have been blinded?
I mean, I don't think it could have blinded.
You certainly can't blind patients to whether or not they're going to operate or not. You certainly can't blind clinicians as to whether a patient is going to be operated or not. Could you have blinded outcome assessors? Well, that also seems a little bit far-fetched, right? It would involve, I suppose, shielding the outcome assessors from the trajectory of these patients altogether and just having them look at the chart a year later. But that kind of seems nonsensical to me. So this is one of those rare studies where I think it's reasonable to not have blinded at all. Remember that the blinding, you always have to ask yourself, how does it bias the study? In this case, I think not very much. So here are the results. So if we say, we've just talked about the internal validity of the study. So if we talk about the results, I've just put them in tabulation form. So we had 26 versus 24 patients. And on the operative side, basically all had appendicitis. There were no complications here. There weren't any major complications here, but a few went on both early and late to have appendectomies, and another 5 had appies but had negative appendectomy and had this operation nonetheless for symptoms. Length of stay was noted to be a little bit different, and then costs were a little bit different. But here's a kind of a philosophical question. First of all, did they assess the right outcomes? Could they have looked at other outcomes besides what they did? Any ideas? And I'll give you an example. Etienne, you're not a parent yet, but Aiden to my left here is a parent many times over. Do you think the opinion of how the family feels about the treatment plan, or how the patient feels about the treatment plan, might be of interest? Could that be studied? You're shaking your head, but no one can see you. So go ahead, talk about it for a second.
Yes, I think you can look at patient satisfaction scores or parent satisfaction scores with the outcome. If I have my child who is being treated for appendicitis and I take them home and I'm worried, are they going to perforate? Is this going to come back? I think that is a very real issue.
Yeah.
So.
Yeah, and I think in many ways, and I've had a chance to speak to some of these clinicians participating in this study, the push to proceed with non-operative management is very much being driven by parents and the desires of families and caregivers. So I think it's really important to have taken into account satisfaction scores with parents. So it wasn't done here. It doesn't mean it's a terrible study, but I just think it might have been worthwhile to look at. So I think they looked at a lot of good outcomes. They could have looked at other ones. How about what was the most important result of this study? What do you think? Think about what they were trying to achieve with this pilot. Of the results I just showed you, what do you think is the take-home message? Is there a take-home message?
I think they would argue that this is safe, that non-operative management of appendicitis is safe, although they had 2 patients that were received appendectomy, one with perforated appendicitis within, I think, 9 days of their initial attempt at non-operative management.
Yeah.
So I think they're as we spoke at the beginning, that the issue of safety is a little difficult to assess in a pilot trial.
But if you can imagine the goal of the pilot, if the goal of let me articulate a pilot project a little differently. So a pilot study, the goal of it is really to launch a good study, and a good study is to test a hypothesis. So if we imagine that this study wasn't trying to test a hypothesis at all, if it was just to see whether a full trial was feasible, do you think they met or failed to achieve their goals? What do you think, Etienne?
I mean, I think they met their goal in the sense that, as we discussed, the trial is feasible and it's safe, and you know, but I'm not sure that, given it's hard because to draw inference from the results that they have in this pilot study is unfair. It's not something that we can really do.
Right. I'm going to cut you off there just for a sec, because the authors correctly don't make inferences. If you look at this, I tabulated this result, these two results here. There's not a p-value in sight, and there shouldn't be, because they correctly have not powered this study to answer any of these questions about is one better than another. What they wanted to look at really is it feasible for us to do this study? And so I think the most important result is it took them 9 months to recruit and enroll and complete 50 patients. So if I was running this study, I would then have to figure out a sample size calculation. Let's say it's going to be 500 patients. It took 9 months to enroll 50, so it's going to take, whatever it is, 6 years to complete the study with one institution. Okay? You also note that an important result is of 220 patients assessed, 50 got enrolled. So that's a very important percentage, and that helps these folks decide how many people need to be assessed as being eligible versus how many actually will be able to be included in the study. It also assesses whether or not people truly believe in the equipoise. So I've seen a few studies where people kind of say, yeah, that's a great idea, let's do a study, and then clinicians, often halfway through or even less, will say, you know what, I actually think I know which treatment is better than another. And so more and more you'll have clinicians pulling patients out of a trial. And just to remind you all how many people kind of weren't put in the study because of an investigator, it was 2 out of 225. So that's not very many, and it suggests at least that the trial can and should proceed. So is this applicable to your institution and patient population? Well, remember now, they looked at kids age 5 to 15 with simple appendicitis. They didn't look at stuff with extreme duration of symptoms. They didn't look at kids. They excluded a lot of kids, for example, with inherent immunodeficiency or otherwise were ill with comorbidities. They didn't look at kids with perforations, obviously. They didn't look at the very young kids. So they did exclude a lot of patients, but you're still left with a lot of pretty straightforward kids with good old-fashioned simple appendicitis. So I think this is a study with some external validity and generalizability. There's no reason to think that kids in Sweden have a different kind of appendicitis than they have here in Canada or in Texas or anywhere else. But a couple of larger concluding thoughts, and then we in Canada have to go and vote, actually. Do you think, Hayden and Etienne, there is equipoise to go ahead and proceed with a larger RCT? Let's say your child or you have appendicitis and you're 14 years old. Would you feel comfortable to enroll in a trial where you either will get surgery or antibiotic? What do you think?
I think my position is going to be a little biased as a surgeon.
Or what about as a parent? Try to take your surgeon's hat off and put your I'm a dad hat on. If your oldest, if Ruby, had appendicitis or right lower quadrant pain, and the diagnosis of simple appendicitis was made, do you feel it's reasonable that we flip a coin to figure out how we're going to treat her? For those that can't see, that was a deep sigh by Dr. Stein right there. Yeah. Yeah, and it's not easy, actually. It's not easy. Equipoise is in the eye of the beholder. And a physician's equipoise might be different than a parent's equipoise. And as I mentioned a moment ago, a lot of this non-operative management strategy is being driven by parental desires. And in many ways, we as surgeons and clinicians are beholden to our stakeholders, and they are children and their families. So there is something to be said for acknowledging the perspective of the parent and trying to acquiesce to that. That being said, is there equipoise? Well, it's hard to say that there is at this point, based on this preliminary data, right? We don't have enough to, I don't feel that there's enough information to reject the idea of an RCT, but let's just say I'm also less than enthused about full participation in an RCT, or I would do so at least with some caution. And any full RCT should be have a very strict sample size calculation and have a bunch of stuff like automatic stops or interim analyses to check for safety, etc. But I have another question, and it's on the slide, but I've looked at the slide long enough so you can look at the two of us. What is there another alternative to an RCT? Do we have to randomize this? Could we do this any other way besides flipping a coin or having the computer flip a coin? Etienne's thinking. Aiden's thinking. We can, and let me explain why. And it's kind of a neat idea. Is why don't we just let the family choose? Can we do that?
Yeah, you can.
You can. You can.
You can do a lot of things.
You can do a lot of things. So here's the catch, though. So that sort of study is an observational study. It's being done right now, and the lead author is Minechi. And I probably mispronounced his name, and I apologize, Dr. Minechi, or Minechi, if you're listening. But it's being done out of Nationwide, and it's got a lot of institutions involved. It's got about 800 patients that need to be recruited, and they're going to let families choose one versus another. And they've done a quick pilot, and they've shown that at least, Alana, thank you for texting in, Alana. She calls it a prospective cohort. I suppose that's reasonable. It's a prospective cohort. Thanks, Doc, for chiming in. And the important difference is it's not randomized, so you're worried. As someone who's about to read this and might change their practice, those two groups might not be the same. So the authors of that paper have to be very careful to try to show that the two groups are the same. But if they can do that, and they can show that whoever chooses non-operative management achieves equivalency, and that again is a loaded phrase, but relatively similar outcomes to operative management, well, now you've got yourselves a conversation. And that leads me to another final point, because we're just about at the hour. If you are going to take this pilot data and go on to create a larger randomized trial, truly randomized, and I'm going to tease this because I want to discuss this at our next journal club. You could do a straightforward, traditional, superiority randomized controlled trial, or instead, you could try to prove that non-operative management is non-inferior to operative management. And non-inferior is a whole different ballgame with a whole different set of statistical challenges. And it can sometimes be more challenging, actually, than showing that something is better. Remember that it all depends on where you put your null hypothesis. So I wanted to share one other quick thing with everybody before we sign off. I'm going to just hope that this works here. So go share this. So did I do that right? Hold on a second. I'm going to stop screen sharing. So what I want to just show you here for a second is some of the online resources that are useful to help everyone. Entire screen, Google Hangouts. Wait a second. Oh boy. Share that. That's no good. Hold on. I just killed you, didn't I? Hold on. That's no good. 1 second, everyone. Where is it? What I want to try to show you is worth looking at. Yeah. Okay, hang on. What I want to show you is some of the online resources that are useful for anyone who's interested in clinical trials and staying up to date with them. So it should be this one. Share that. Shoot. A moment. Can you see this? Yes. So are you all, Etienne at least, can you see that I'm looking at a web page?
Yes.
And now the web page shows clinicaltrials.gov, right?
Yes.
Good. Okay, so I want to show you guys a few websites that I think are very useful that everyone should know about. The first one is clinicaltrials.gov. Clinicaltrials.gov is a repository, an American repository of all trials, really, that have been registered and that have either been done already or are being done. So if I type in pediatric appendicitis, sorry, appendicitis, I'm not cripes, and there we are. Yeah, do that. Okay, go Barry. So if I do that, now you have a list of 16 studies in here for pediatric appendicitis, including pathway care, 3D ultrasound, CT scanning, patient activation tool, and here is one called non-operative management of pediatric appendicitis with appendicolith, multi-institutional trial of non-operative management of appendicitis. So if I click on that one's terminated, it died. This one is the large one by Menetzi. Again, I'm just going to click on it and show you guys. And Nationwide is running it. And if you're interested in this topic, this is how you find out what is being done. So it's an observational, case control, prospective study. It's trying to enroll up to 800 people. And it's expected to complete in 2019. So you got an interim analysis coming up in about a year, year and a half. And so it's a terrific way of knowing what's sort of currently being done. There's a European version. It's called Clinical Trials Register. Here it is. It's a little less well populated than the American one, but certainly if a trial was going to be registered in Europe, this is where it would be registered. Finally, I wanted to show you guys a couple other quick tools. First is a critical appraisal tool here. I'm a little biased. I acknowledge that in advance. I did some of my training at Oxford. They have a wonderful Center for Evidence-Based Medicine. Here it is here. And they have a bunch of critical appraisal tools. So if we just go and look down at some of the English, if your German is great or your Spanish is awesome, you can do it in different. Lithuanian, fantastic. But here you can look at therapy or randomized controlled trial critical appraisal sheet. And that is a sheet that helps you go through the internal validity, helps you look at the results, and helps you ask questions about external generalizability. I base a lot of the flow of my presentations on these sheets, and I encourage everyone to have a look at them. And the last webpage I want to show you all is the CONSORT statement. CONSORT stands for Consolidated Standards for Reporting Clinical Trials. And it's a lot of what you typically see when you read a randomized controlled trial. For example, the flow diagram of all patients, the standard reporting of baseline demographics of patients enrolled and eligible. That all is included in the CONSORT statement. So if, for example, you wanted to embark upon a trial, check out the CONSORT statement. You need to be adherent to it. If you're trying to look smart and want to critically appraise something, again, look at the CONSORT statement, because that's going to help you ensure that the trial is worth its salt or not. Finally, a reminder that good studies should register their trials with clinicaltrials.gov, should obviously have internal ethics review, and should ultimately, here we're going to put a dog face on me, and should ultimately have whatchamacallit, a strict adherence to the CONSORT statement. And those are really the three things that I look for. The last thing would be a financial disclosure to make sure that people aren't beholden to the people that are paying for the study. But if I see those 3 or 4 things, to me, that tells me that this is a study of quality. And the last one, which is a surrogate, is where the study is published. And it's not always true, because good journals sometimes publish bad articles. But in general, the stronger the journal, we usually all know which are the strong journals. In general, they have stricter guidelines, and they tend to publish better studies. There we go. Did I do that right? There. So now Hayden's got a little devil thing. Listen, I'm going to put a little crown on me. Listen, so thanks to all for listening. I want to thank Etienne for taking an hour and a bit out of his day to come talk to us about this study. Dr. Stagg as well for his insights. And again, as always, thanks to the online Journal Club forum, supported by the Hendren Project. We're going to be doing another study, in fact, part 2 of a randomized trial, because there's lots more to discuss, in about a month from now. And again, thanks very much, and we'll see you then.
Thank you.
Okay, bye everyone.
Bye-bye.